Hi, everyone, and good morning to everyone in India and Malaysia. Good evening or good night to everybody else. It's almost midnight for me here in Canada, but I'm delighted to moderate this very interesting webinar with two amazing health leaders we've known. Health Minister K.K. Shailaja from Kerala State in India, and Dr. Noor Hisham Abdullah, the Director General for Health in Malaysia. My name is Madhu Pai. I'm a professor of epidemiology and public health and global health at McGill University in Canada. I am the director of the McGill International Tuberculosis Research Center. I did my public health training from India. And I've been actively involved in tuberculosis and COVID-related work. And so it's my honor to moderate the session. I will say a few words about the two co-hosts of this webinar, DNDi, which stands for Neglected Diseases Initiative, and the COVID-19 Clinical Research Coalition. DNDi is a nonprofit R&D organization, and it is world famous for tackling some of the world's most neglected diseases, which no pharma company wants to work on. They have pioneered a range of innovations using an alternative model to the traditional pharma approach of developing drugs and vaccines to develop treatments. They've developed 8 treatments for 5 neglected diseases, including an all-oral treatment for sleeping sickness called flexinidazole, which is a revolution because it has managed to make treatment for sleeping sickness so much easier than the previous toxic treatment that was used, which was very toxic and dangerous for patients. One unique thing about DNDi is that DNDi is primarily funded and supported by many low and middle income countries. Which is one of the reasons why DNDi is able to focus on neglected tropical diseases that nobody else wants to fund. For example, some of the founding members of DNDi includes Doctors Without Borders, governmental institutions in Kenya, India, Brazil, Malaysia, France, along with World Health Organization. So in fact, India and Malaysia are both supporters of DNDi. In fact, DG Hisham is actually a member of the board of DNDi. The other partner in this organization, which has been jointly started by DNDi and many other resource-limited countries, is the COVID Clinical Research Coalition. The idea here is much of the innovation around COVID in terms of vaccines and medicines are happening in some of the richest countries in the world. But when these products come to market, it is not quite clear whether low and middle income countries will have access to those innovations. So it's quite important that low and middle income countries also innovate on their own. And that's what this clinical research coalition hopes to do. So together, DNDi and the Coalition for COVID Clinical Research are hosting a series of webinars. And this is the first webinar in that series. So we're very delighted to have all of you. So I'll very briefly introduce our two health leaders. Madam K.K. Shailaja is the Minister for Health, Social Justice and Women and Child Development with the Government of Kerala in India. She's also the State Secretary for the All India Democratic Women's Association and Joint Secretary of its Central Committee. She's popularly referred to as Shailaja Teacher. And if you have seen the movie Virus, released last year on Amazon Prime, you will actually see her, not the real her, but Revati, the actor, playing the role of Shailaja Teacher, demonstrating the incredible work she and her ministry did in controlling the Nipah virus outbreak in Kerala in 2018. Madam Shailaja was recently honored by the United Nations on the occasion of the UN Public Service Day for her exemplary efforts to fight the COVID pandemic in Kerala. Thank you, ma'am, for joining us. Dr. Noor Hisham Abdullah is an endocrine surgeon, and in fact, he just told us that he still practices medicine and sees patients every week. He is the Director General for Health for Malaysia since the year 2013. And prior to that, he was the Deputy Director General of Health. As I mentioned earlier, he sits on the board of DNDi and chairs multiple national and international committees. He has received many, many awards and honors for his incredible work in addressing health, including a fellowship of the Royal College of Surgeons of Edinburgh. And in Malaysia, he is the public face of this pandemic response by the Malaysian government. He directly communicates every day through Twitter to thousands and thousands of followers and updates them on the status of the pandemic. And between the two of them, these leaders have done incredible work in terms of setting the trend for how countries can and should respond to the COVID pandemic. I think what is striking about both of them is that they acted very early. They took all the warnings from WHO and other partners seriously, and they mobilized an incredible response using all their resources at their disposal. We have lots to learn from Kerala and from Malaysia. And although the pandemic is not gone yet, both Malaysia and Kerala are seeing a resurgence in cases. It's important for us to learn what they did right, what they plan to do in the coming months since the pandemic is not gone, so that other countries can benefit from these lessons. I will now begin with Madam Shailaja. Please, ma'am, in about 5 to 10 minutes, tell us what is the current COVID situation in Kerala? What sort of a response did your government plan? And where do you see this going in the next few months in terms of responding to this crisis? Over to you.
Yes. We can say that this is the third phase of the pandemic in Kerala. First phase, the people who returned from Wuhan, we got 3 positive cases and we tackled that problem successfully. And no other transmission occurred from them, and they cured well and sent to their home, and no other transmission occurred. And the second phase, so many people returned from Italy, UK, USA, and all part of the world. Up to March 24, they are coming, and that time also we have had a very good action. Our slogan is that trace, quarantine, test, isolate, and treat. At that time, so many people are saying about test. But at that time, we have a very good strategy, a scientific strategy for testing. And we followed this method, tracing them from the airport, seaport, and also from the checkpost. We were tracing them properly and sending them for home isolation, that is room quarantine. And with the help of local self-government, we make it assured that they are obeying the quarantine principles. But someone jumped quarantine, and most of the 80% of them obeyed the quarantine rules, the regulations and guidelines prepared by us. And at that time, up to March 24th, we got so many cases from abroad. At that time, in India, it is not rampant here. It was not rampant here, but from abroad, we got so many cases. But on March 24th, here the government declared the lockdown. Central government declared the lockdown, and we got the cases under our control. No other persons were coming at that time, and we are able to make our public health system to proper action, and we acted well. We have, as I said earlier, we have a very good pre-preparedness in Kerala. We have a very good public health system here. And with the help of that private health system and the 18 expert group we formed especially for this COVID, tackling the COVID. And with the help of that expert groups and all the 14 districts, we have control rooms and experts there. And we activated our system very well. And from March 24th to May 3rd, it is a period of lockdown. At that time, we acted well. And at that time, the Local transmission is 23%, below 30%. But we want to reduce the local transmission, and we acted through the local self-government, the panchayat samithis, etc. And we gained a very good result. That time only 3 deaths happened. Up to May 3rd, we got 499 cases, positive cases from the returnees and from the local transmission also. And local transmission is only 23%, but that is a we are thinking that that is not a good percent. We want to get it below 10%, and we tried our best, and that was the result. Our case fatality rate was only 0.5%, and R0 rate is also 0.25, and we yield a very good result out of that. But after May 4th, the situation changed. The lockdown was lifted, and from all part of the world, the people began to return to Kerala, and we cannot stop them because they are Malayalis. They want to return to their home state, and they were returned. But our tracing system is strengthened well in the airport, seaport, and also in the by people who are coming by road. Our tracing squad were there, and we traced well. At that time, in India also, it become in certain cities, it become rampant, and some of our cities like Chennai, Mumbai, and Delhi become epicenter of this virus, and virus load was very high there, and people began to return from that place also. Malayalis are everywhere in other states also. It is not thousands, it is lakhs of Malayalis are there, and they also started return to Kerala, and that was a real challenge at that time. Now also it is a real challenge, but we traced them properly, and after 3 weeks after the lifting of the lockdown, our local transmission is below 10%. That was also a very good achievement. But now the situation changed a little bit, because our neighbor states, Tamil Nadu and Karnataka, the transmission is very, very high in that places, nearby district. And from the nearby districts, people are traveling to Kerala, because interstate travel is allowed now, and no restriction for the interstate travel, and they are coming not only through the checkpost, but they are coming through the local or village paths, and someone we cannot identify them, and some trucks are coming with eatables and also fish, etc. And our coastal zone become something difficult now, and in the coastal zone, the fish market and among the fishermen area, we got a spread there, and some clusters are formed. Now we are doing with the cluster management strategy. We prepared a cluster management protocol and cluster management strategy. We are closing the cluster completely. No one is entering into it, and no one is coming outside from the cluster area, that is containment zone. And we are watching thoroughly, and our test also increased. We are testing. Our case per million is now 300, and our test per million is 18,000, and that is a good number. We can say so. We are increasing the test, and we had now 43 deaths here. That also we cannot. We are not. We are now trying to reduce the mortality rate and giving proper treatment in our hospital, and we are checking the hypoxia, etc. Most of the deaths we can say because of the hypoxia, silent hypoxia is there in the case of this virus, and we are trying our best to reduce the mortality rate. Now the mortality rate is 0.36. That's a good result, but the 43 death we can't afford that. But most of the 80% of the deaths are above 70 years, and with so many comorbidities. Only 4 deaths happened without proper other comorbidities, etc. All some patients were cancer patients who were undergoing prolonged treatment, and some had heart problems, etc., cardiac something, that kind of diseases. And we had 43 deaths up to today, and we are now trying to reduce the transmission rate. We are closing the cluster, and we are not allowing to coming out of the transmission cannot be occur outside the cluster. We are doing it properly, but it is a difficult task. It's a challenge. So many people came from other states with high virus load. Task to find out them in villages, that they are going to villages, they are residing there, and we are testing. Our surveillance is also, we are increasing surveillance test also, and that is the situation here. Now we are struggling with these clusters, but we are enthusiastic that we can tackle the problem this time also. We are working hard to do that.
Thank you, ma'am, for a very honest and candid response. I know it's a difficult time for you, and it must be hard to see this surge in cases. We are confident that your ministry will overcome this challenge. We will come back to you with more questions. Over to you, Dr. Hisham. Please tell us a little bit about how Malaysia has handled the epidemic so far in the first 6 months, and where do you see the challenge going forward?
First and foremost, I'd like to thank Mother Kai for chairing this session, and thank DNDi for organizing this. And I would like to start with in December last year, whereby when we first heard about the Wuhan outbreak, it has given us time to prepare our response. And more important that we are, instead of being denial, we have accepted the fact that it is inevitable that the virus will reach our shore in any time. So we started reactivating our National Crisis Response and Crisis Preparedness and Response Center. And also in every state, we have 14 states, so we activated. And this center coordinate and integrate our preparedness and response. And we have the experience in the past whereby we managed to handle Nipah virus, SARS, MERS-CoV, and HIV, H1N1. But that experience have given us the preparedness and the response protocol and the department and unit. So this CPRC is very important, is the heart of the center of the response, whereby we coordinate in the Ministry of Health and come up with, although we have been given 2 months prior to our first patient, but in terms of the training, guidelines, the protocol, the logistic, the reporting, the data collection, everything we have put in place. And thereby, before we get our first patient, then we realize that we need to diagnose the virus. And on the 3rd of January, when China released their genomic sequence, our Institute of Medical Research prepared the prime our lab in terms of getting the RT-PCR test, and we managed to get our protocol for the RT-PCR test before WHO released the protocol for testing. And we started training our labs in the public sector and the private sector, in total 24 labs, because we realized that to fight a war, we need to identify the virus. If we are not able to identify the virus, then it will be difficult to us to go down to the field. And we train our labs. At that point of time in January, our capacity is only about 1,000 tests a day. And our first patient, that is, we had our first patient on the 25th of January. The index case was in Singapore, but the whole family came to our Johor Bahru, and from there we activated our active case detection. We managed to identify them, and then test 4 of them were positive. So we already identified our quarantine center and isolate them and give them proper treatment. Those positive will be admitted. So our policy from the day one is all positive cases will be admitted to the hospital, whereby the negative patient exposed to a positive test PUI will be isolated and quarantined. So we have identified our training centers and etc. for quarantine, identified all our hospitals to accept in terms of to place those positive patients. That's one response that we have started in terms of the lab. Second is that we enhance our public health. So we have 6 initiatives initially that we have planned. First, it is actually enhancing the lab capabilities to test. Second is surveillance in terms of getting our hospital facilities, whereby our hospital is very congested, but we managed to decant the services to a district hospital, and we have 7 hospitals just for COVID patients, and we have 33 hospitals, a hybrid, that means treat COVID patient and not. So we have in total 148 hospitals in the country, but we have identified 40 hospitals to treat COVID patients. And we have started procurement of the ventilators and mobilizing the manpower and etc. Then what is more important is that when we comes up first wave, we have the first wave from case 25th of January until early of February. The first phase mainly involved tourists from Wuhan, directly or indirectly. So they infected some local as well. But then we have a period of 11 days without any cases being reported. That is where the calm before the storm. And come case 23, whereby we realized that Malaysian coming back bringing the virus are not only from China, but coming back from Japan, Korea, Italy, and Iran. So we started to exercise in terms of border control of these 5 countries. And then school holidays around the corner, and we were told that maybe 10,000 of Malaysians will be going to for a tour in Japan, Korea, and etc. during a school holiday. So we advised our Prime Minister. So we have a political turmoil for 2 weeks. There's no government in place, but we continue to do what we do best. That is to have this public health intervention. Then when the Prime Minister came, so we emphasized to the Prime Minister, the new Prime Minister, that he has to do something important here. That is actually to lock down the whole country. And this Prime Minister listened to us and trust the civil servant. So, and because of that, the implementation of our first lockdown in MCO, Movement Control Order, using Act 342, we started doing implementing it on 18th of March, and we started for 2 weeks. That is actually to prime and mind condition the public to accept 2 weeks, and then we extend another 2 weeks, and then 2 weeks total, or 6 weeks. And during the 6 weeks, we managed to flatten the curve. So once the curves have been flattened, then we change our strategy, because essential services will continue doing the lockdown, but the economic impact. So we need to balance the life and livelihood. So once we control the virus in the artificial environment, and we manage to bring down the curve, then we allow the economic sector to come back. So we change from MCO to CMCO. CMCO is Conditional Movement Control Order. In between, because the MCO and CMCO, if there's an outbreak in locality, we will enforce the enhanced MCO. That means we come in and we quarantine the whole area, we swab everybody, whether it's local, whether it's a foreign, legal or illegal, we swab them. Positive cases, we'll isolate them in a hospital. Negative cases, but exposed to positive, we'll quarantine them for 14 days. So this is our initiative from day one. And we do the EMCO in certain area, high locality, high risk area. You come in and we continue to enhance the MCO. So by doing so, 6 weeks later, we see the flattening of the curve. And you can see that, once we flatten the curve, we change to CMCO and have a festive season end of the CMCO. But we thought that we will have a surge of cases, but we managed to control in terms of the response. The response is not only the Ministry of Health. The response is the whole government approach. Although CPRC is the heart of the response, then work with other agencies and ministries. For example, on border control comes under the immigration and also the army. And the interstate travel roadblocks come under the police. So it's actually a very comprehensive whole government approach. And we also have the NGOs, the society to participate in. So actually a whole government and whole society approach. So then we are, at the moment, we succeeded in the CMCO. That is to open up the economic sector but control the spread of the virus. Then now we move on to the next, the recovery MCO. The recovery MCO is recovery movement control order is mainly to open up other sectors, the social sectors and the education sectors, and we monitor closely in terms of the virus, the spread of the virus. So you can see that our recovery in terms of infection from the COVID is almost 97.22%, and we have actually sampled more than almost about 900,000 cases. Our positive is about 0.98%. And those active cases been admitted to ICU, although they are asymptomatic or mild symptom, we still admit them to our hospital. Severe cases need the ICU. Today is only 3 patients, and only 1 patient need ventilator. So we have procured more than 1,054 ventilators. And good collaboration between the public sector and the private sector. The private doctors also come, volunteer to work in the public sector. So we have 2,500 manpower coming from the private sector and those retired to serve the Ministry of Health. So you can see it's a whole society approach coming in to everybody have a common goal. What we did was prepare for the worst and hope for the best. And the whole government approach helped us in terms of to bring down the cases.
Thank you, Dr. Hisham and Madam Shailaja. So both of you clearly have led from the front. You acted early. You pulled together all the arms of your government to respond. You had a very comprehensive strategy of testing, tracing, treating. It wasn't any one thing. You both used the lockdowns on movement restrictions effectively. And both of you have had prior experience in dealing with outbreaks. The Nipah virus in Kerala is a very famous story, and Malaysia also had Nipah virus and H1N1. How much do you both think your prior experience with dealing with outbreaks prepared you and your system for this current crisis?
Yes, first of all, I want to convey my congratulations to respected DG Malaysia, because their fantastic experience and how they get this curve down, active cases and also death rate, and that is an example to the whole world. They are also looking to Malaysia for the experience. And the Nipah virus came to Kerala also in 2018, and I think that the name got from Malaysia for that virus, Sungai Nipah. And when it occurred in Kerala, we surprised and we feared really, because that is a virus, a cruel virus with high mortality rate, and everyone is saying that it is a killer virus, and the infectivity rate is low, but nothing good out of that, because the mortality rate is too high for the Nipah virus. And we acted well with the experience. We also inquired what happened in Malaysia at that time, and with that experience also, keep in mind that experience, we have very good. We had a very good protocol and SOP to tackle that Nipah virus. That is a very good experience, And from that experience, we happen to know how to trace this virus and how to quarantine, how to isolate, and how to treat these rare cases. And that experience helped us very much during this corona period. And with that experience, at once we started all that system we had at that the Nipah virus time. And at once we formed our rapid response team. At once we formed the expert groups to each and every duties, that tracing, contact tracing, and quarantining, and also for logistic correction and everything, even finance also. And we formed that expert groups, and we started action out of this great experience. Nipah occurred second time also in 2019, only one case, and we contained that with that one case at once. and we are conducting mock drills each year for the Nipah virus, and we are training our public health staff. If Nipah virus occur, what will you do? We are giving proper trainings each and every year, and that trainings and that experience helped us very much during this season.
So Kerala had a strong public health system, but the outbreaks made it even stronger. Is that correct?
Yes, yes. We have good public health system from 1957 onwards. We are building this public health system. We have so many reforms here, land reforms and education reforms, etc. That also helped. Especially the last 4 years, we are doing a very good thing in health sector. We have a special project called Ardhar Mission. Through that mission, we are strengthening our public health institutions. Health center, we are converting the primary health centers to family health centers, providing 3 doctors instead of 1 doctor, and some clinics are also we are decentralizing for the public, and we are doing such kind of exercise here and strengthening our public health system. We strengthened a lot, make it technologically modern and make it people friendly. We are doing that. That also helped us. I'm speaking about the state only.
I know.
The country as well. I think death rate is it is not too high, but it is increasing. It is increasing now, and also the positive cases are also increasing.
I know.
Here in Kerala, we are practicing some systems just like Malaysia, and we cannot equalize these two because Malaysia as a country as a whole, they achieved a very good result. And I am speaking about my state only, but we are doing like Malaysia.
Thank you, ma'am. Dr. Hisham, so yes, you had mentioned the importance of how the prior outbreaks prepared you and your country. Can you tell us a little bit about it?
Yes, the past experience, for example, gave us an opportunity to strengthen our healthcare system. And we do have the International Health Regulation 2015, but the experience that we had, so it's looking into the health facilities system in place, looking into the organization, looking into the logistics, manpower deployment, and etc. But at the difference is this is the COVID-19 is on a larger scale. But that experience very important for us to coordinate, to integrate, working not in silo, working the whole government approach. Normally we respond in the whole ministry approach, but today you look into it because this is a pandemic. We are using the whole government in terms of to enforce what we have decided in our policies. And this is where I think coordination helps us to make fast decision and the implementation. So the implementation is not only Ministry of Health. For example, the border control. So we get the immigration department in straight away. We make a decision today, tomorrow we implement it, or day after tomorrow. So that's where I think our response is fast and as well as timely. And we discuss issues and challenges. And we continue to discuss this at every morning we have a meeting. 8 to 9 o'clock will be in the Ministry of Health, and 9 o'clock to 11 o'clock in the morning for the last 3 months, inter-ministry, whereby we address all issues. And sometimes we argue, but then we come up with a collective decision and we implement it. And there's actually good leadership in that sense. Then we can actually enforce it. And certainly because of that, we can see results. But there's also a lot of arguments. For example, we want to open up more sectors, and I say no because the acceleration phase. How can you open up other sectors when the acceleration phase, the virus is not under control? So again, this is we put up the discussion, and then amicably we come up with a solution, and that solution we implement it fast. So whatever we do in terms of engaging with other ministries, and then as well as using the system and the guidelines from WHO. So WHO guidelines, evidence, and when we react or we implement, it's based on evidence, not based on politics. So evidence comes in, facts and science, and not fear and rumors. So this is a very important basic for us to move forward. Whatever we do is evidence-based.
I want to ask you that's a very important issue, Dr. Hisham, and we were speaking about that, about how there is this rising trend of anti-science in many parts of the world, including some of the richest countries in the world, and how experts have been sidelined, public health agencies have been sidelined. So in Malaysia and in Kerala, from what both of you have said, you have trusted your experts, you've trusted your scientists, and you've listened to them. Can you tell me how important do you think this is in this pandemic?
I think this is the most important, that is to manage the public expectation. And if the public believes in non-science, that's actually beginning or end of the whole control system. So what we did is strategic planning, strategic communication. Every day without fail, there will be two press conference. One non-medical, that is from the Minister of Defense. And he will address all the non-medical, that means from the police, from the army, every implementation for COVID-19, but non-medical issues. I will address every day without fail at 5 o'clock, engage with the public live, and then that's where we explain all the issues and challenges and the facts, and also we allow the reporters to ask questions. And all the questions, hard questions, we will answer there and then, based on our experience. If we know, we will based on the facts and science. So that engagement gives the public trust. So once the public have the expectation of listening to us, and then the public will have public expectation to the Ministry of Health and the government effort. But our role is to deliver beyond that expectation. For example, when we say we only have 1,000 lab tests a day, then we continue to escalate the tests. And then now today we have more than 50, we have the 56 labs now, but we deliver in terms of the capacity. We say that we will deliver in 10,000 in 2 weeks, we deliver in 2 weeks. And then now our capacity is 37,000. So everything, every issues that they have, we answer the issues. So if we manage to answer issues, you build trust.
Thank you. So I think public faith in both of you and your ministries is also a critical, positive thing in favor of both Malaysia and Kerala. Going back to Madam Shailaja, Madam, during this lockdown, we know many thousands of people in India have not been receiving good care for other diseases, whether it's tuberculosis, whether it's maternal health, whether it's diabetes, cancer. There's a lot of backlog of patients who've been waiting and waiting for all these lockdowns to lift. And now many cities are going back into lockdowns. So there is tremendous amount of morbidity that still needs to be taken care of. How do you see Kerala addressing all the backlog of other diseases that you need to diagnose and treat? And is your health system ready in terms of public and private, the one government approach to deal with all the non-COVID morbidities?
Yes, from the beginning itself, we are giving equal importance to COVID and non-COVID treatment. And we had a very good organization for non-communicable disease here, special projects for non-communicable disease. From the beginning of our government itself, we have a very good non-communicable disease tracking system, and also the other infectious disease other than non-COVID also. And at once we appointed a special district surveillance officer for non-COVID diseases, and one district surveillance officer especially for COVID, and other especially for non-COVID diseases. And we have an equal balancing approach we are taking. And our COVID hospitals are especially for COVID hospitals. Some medical colleges, both these things are doing that. One part for especially for COVID and other part for non-COVID things. And we are strengthening the two things at the same time. And we are appointing specialists for duty, and we are giving charges to that officers for non-COVID things also. And we are also implementing One Health approach here. Even the private sector, not only the private sector, but also the veterinary and other system also, we are joining together to have a One Health approach here. and we are eagerly watching whether H1N1 is increasing or dengue fever, etc., and source reduction, etc. We are giving equal importance to that things also, and we have a good result that this time the dengue outbreak is very low, and H1N1 also it is lesser than previous years. That is a good achievement. We are tackling that problem also. Special teams for COVID and special other teams for non-COVID things.
Thank you. Lots of questions have come in, and I will pick a few questions to ask you. One is this issue that we briefly discussed earlier. There's a lot of drug development and vaccine development happening in some of the richest countries in the world. But then there's also been instances of rich countries buying stocks of remdesivir or buying up PPE equipment. So there's a lot of anxiety that these tools may not reach low and middle income countries, even if they are indeed and developed in the near future. So it's important for, I think, countries to plan for that and make sure that they have access to the best tools. So how is Malaysia and India thinking about developing new diagnostics for COVID, new vaccines and treatments, or at least actively investigating them in clinical trials so that you will soon have access to use them if they become available? DG Hisham, would you like to go first?
Right, thank you. So we look into our public health response, so much so our response is working very well, and we see less patients now in our hospital. But nonetheless, we work with other organizations whereby in terms of the trial, at the moment, from the beginning, we started using off-label for hydrochloroquine, even lopinavir, ritonavir, and etc. But off-label usage, and also we collected the data. And after 6 months, 4 months, then we review the data whether there's actually any advantage and disadvantage of doing that. So we do a small clinical trials on our side. But we also joined with WHO for a solidarity trial, looking into it. And now in terms of the usage of hydrochloroquine and lopinavir and ritonavir being stopped, but the remdesivir is actually still ongoing. But we have been allocated 100 patients, but we do not have the 100 patients in ICU, for example, we only have 3 patients. So, but the trial is ongoing. But the next is actually we work with a vaccine company, Sinovac, for example, and Sinopharma, looking into phase 3 clinical trials locally. So that has been discussed, and then we are negotiating. But again, our cases are not there. That's the thing. We also continue discussion with other organizations like CEPI, Coalition of Epidemiologists, Preparedness, Innovation. So that has been, we are part of that research group, and hopefully we can continue to research for new vaccine in place. So we, to enhance further, we encourage our Institute of Medical Research to collaborate and also to work with other agencies to use Malaysia as a platform, as a hub for the clinical trials. So not basically a phase 3 clinical trials we are able to actually cater, and we are being recognized as one of the center for clinical trials now. And it's very systematic, and our doctors are trained in the clinical trials. So this is a platform that we invite other companies, whether it's a drug or whether it's a vaccine, to come to Malaysia to do the clinical trials.
So there's a lot of discussion that if and when a vaccine becomes available, wherever it is, that it shouldn't be an Oxford vaccine or a Chinese vaccine, it should be a global good. Do you believe that a vaccine should be considered a global good and made available to all people all over the world?
Yes, I certainly do. And perhaps we need to re-look back again how we can, work together globally, looking into organization and to come up with, the patent of the vaccine. So these are issues that are ongoing. We have done it for drugs, for example. Like hepatitis C and etc. But can we use other model One model that we are looking into full procurement. So if we can have a full procurement, not only locally, but regionally, and that probably there's a way forward. Second is that when we look into collaboration with other countries, even other organizations, is how best that we can deliver this vaccine or even drugs to the certain countries. So it can bring down the cost, that's important. Then you have the volume, then you bring down the cost. So this is one way of doing it. The other is probably is that if we invest in the organization, like CEPI, for example, Ministry of Health and the government of Malaysia is investing as well, and in the research. So we hope that we will be part of the organization if they can find the vaccine. Then we offer in terms of manufacturing in Malaysia. Although vaccine been identified or available, and Malaysia can be a hub for manufacturing. So I think we are looking into various ways of access in terms of to solve this issue of vaccine. But today we do not have vaccine yet. But nonetheless, if you look back in the past, for example, Nipah, SARS, as well as MERS-CoV, we do not have vaccine then, and we do not have vaccine now. But we managed to eradicate using public health control. So that is the most important that we should do now while waiting for vaccine. Then we hope that we can actually eradicate or bring down the cases of SARS-CoV-2 using the same methodology. So I think we hope that that's the best way to go ahead.
So you were saying while we work on the vaccine access, we definitely need to use everything that we know about public health right now.
Right.
We fully agree with you. Madam Shailaja, so India has already produced some indigenously made diagnostic tests for COVID, and I believe your state has already used it. India also has some vaccine candidates, and India is the world's pharmacy in terms of producing generic medicines and vaccines. So how do you see India approaching the whole R&D angle?
Yes, our country is also participating in this research, and we are also a candidate in this research of vaccine. And we are in hope that we also will win in the vaccine development. But the Oxford vaccine, that I think it is in the final stage. Ours is not in the final stage. And we cannot wait for our own vaccine, because if the Oxford vaccine become a success, it should be accessible to the whole world.
Yes.
That is the morale of the health sector. And that should be conveyed to each and every country, and we also hope that we will also get it. Some medicines, as you referred here, that remdesivir, etc. I think it is not fair to make it under the monopoly of some places, and we should also get access with that kind of medicine. We are also trying these lopinavir, remdesivir, etc. here, but there is a scarcity of that medicine in the market, especially for remdesivir. Now we are trying the plasma therapy, etc. And we fear that the same case will occur maybe about the vaccine also. That should not happen. The vaccine should be accessible to the whole world.
Fully agree, ma'am. And also, just to mention to you, there's a lot of anxiety that since India is the biggest manufacturer of TB medicines, antiretroviral medicines, malaria medicines, that if India doesn't ramp up the production of these medicines, then the whole world will struggle to use and treat TB, AIDS, malaria, and other diseases. So I hope Indian companies will start manufacturing these essential medicines, because the whole world is relying on India to produce medicines for critical diseases. So we are almost out of time. So what I will do now is to just briefly summarize what I have heard from the two of you and what I've read about the incredible work that you have both done in your respective regions in terms of how you managed to successfully deal with COVID, even though the disease is still there and is coming back. But there are still critical lessons to learn from both Malaysia and Kerala. One, and first and foremost, is absolutely incredible leadership from the two of you. that you are the public face of your ministries. You are willing to engage with the public and the media, and you've shown exceptional leadership in this crisis, which I think is really critical. Secondly, as DG Hisham said, you managed to mobilize the whole of your government, not just the health department, but all other departments in tackling this crisis with you. Both of you have invested in public health over a long period of time. Both of you have prepared because of your prior experience with outbreaks in your area. And I think the trust in experts and science that you have displayed is quite exceptional, that you have backed your experts and you've allowed them to do their work. That both of you have exceptional high levels of education and literacy and gender equity. And I think that really matters a lot in this crisis. Your public is willing to listen to you and go along with your guidelines, which is, I think, also very critical. Both of you acted very early, before most other parts of the world, and you imposed movement controls and other public health surveillance approaches. You have both used all the public health tools at your disposal: surveillance, contact tracing, use of technologies like apps, public-private partnerships, and so on and so forth. And I think lastly, you have continued to stay on this. You've not relaxed your work just because the cases went down. But the sobering part, as we've learned from Madam Shailaja, that the virus will come back, that nobody is safe until all of us are safe. So I think we need to really think about the response as a global response. Even if Kerala did well, Kerala is still part of India. And if all of India is suffering, Kerala cannot be safe. And I think that's true for this entire pandemic, that no one country can call itself safe. No country can build walls around it. That we must work to eliminate the virus or control it in every part of the world, no matter where the problem is. And that means we need to share our best knowledge to help others to tackle the crisis, which is what the two of you have done in this webinar. You've shared your knowledge and your expertise. And we should also share the tools like vaccines and drugs and personal protective equipment and other expertise. I think solidarity is the buzzword in this. And I think solidarity is what is lacking in this pandemic, but the two of you are demonstrating that it is possible to not just the two of you, countries like Vietnam, countries like New Zealand have shown exceptional courage and ability to do things that other countries need to learn from. So we are very grateful to both of you, and on behalf of DNDi and the coalition, we thank you for your exemplary work, and we wish you success, because you still need to deal with this resurgent virus. So the battle is far from won, but we are very grateful to you for your leadership and your time. Thank you very much.
Thank you.